Hello everyone, and welcome to our Clinical Decision Support Tools in the Management of Work-Related Musculoskeletal Disorders webinar with Dr. Douglas Gross. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships. As I mentioned, my name's Tanya, and I'm moderating the session and handling the Q&A today, and our speaker is Dr. Doug Gross. Dr. Gross is a professor in the Department of Physical Therapy at the University of Alberta in Edmonton, Canada. Doug's research focuses on individuals with musculoskeletal conditions, including prevention of work disability, functional evaluation, as well as investigating the effectiveness of clinical and public health interventions. He's given numerous national and international presentations and published several articles and book chapters, and we're very glad to have him with us today. I will hand it over to you now, Doug.
Okay, thank you very much, Tanya. Thanks everyone for joining us today. Glad to spend an hour with you. I just trust that everybody can hear me. I'm going to go right ahead with the presentation. So like Tanya said, I'm a professor of physical therapy at the University of Alberta. So physical therapy is my clinical background. I worked for several years, both in private practice physical therapy clinics as well as at Millard Health Centre, which is a large rehabilitation center that's owned and operated by the Workers' Compensation Board. And the bulk of my clinical work was related to individuals who are off work because of musculoskeletal conditions, back pain, arm pain, fractures, dislocations, so forth. And I became very interested when I was working clinically about both things that influence return to work, but also the things that I could do or that we could do as a healthcare team that could influence the prognosis of these individuals and increase their likelihood of returning to work. And so one of my research focuses is on clinical decision support tools in the management of this population. Now I do have this healthcare background, so I'll be, for the most part, taking a healthcare perspective on this, but I realize that there are other people with us who are frontline stakeholders that aren't working in a traditional healthcare setting. So I would say right off the bat that some of our research has looked within the business and management literature, trying to find tools or technology that has helped to select interventions or treatments for this population at the workplace. Unfortunately, most of the research has been done in healthcare, and I don't have a lot to say about that, but I'll do my best to make it a very broad perspective. I do have my email address on this if anybody wants to follow up with me later on. Okay, so our objectives today, what I hope that you'll learn, right off the bat, I'm going to give a definition of what a clinical decision support tool is, the context to using these tools, why we use them, why they're important, the rationale for using clinical decision support tools in practice. I'm going to talk about a study that we did that reviewed the literature very broadly and tried to come up with an inventory of CDS tools for making treatment decisions for injured workers with MSK disorders. And then lastly, I'll talk a little bit about the evidence. How strong is the evidence? I'm not going to do a formal critique, but I'll talk broadly about the number of articles that are supporting this, or what is the status of the literature around CDS tools. I'm going to start out with a quote from Daniel Susskind. Some of you may have read the book that was published this year by Daniel and his father called The Future of the Professions. I'll come back to that book, but I listened to him talk a couple of weeks ago, and one of the quotes that he had that struck me was this: "Technology is the worst it will ever be." This is very true. If you take a look at the computer that you're working with, or the iPad or iPhone, whatever, the smartphone that you're working with and listening to me on, today is the worst that will ever be. Technology is constantly evolving and adapting and improving, and hopefully it's becoming more useful. The first computer, a picture of it here on the screen, first one was created in the 1940s, 1949, this EDVAC computer, and it was very large. It was big enough to fill a complete room with the different transistors and so forth. Although it was large and slow, it did have some important functionality. It could calculate and it could compute. It could do some things much faster than a human could. Well, since 1949, computers and technology have advanced very rapidly, and now hardware is way faster, has way more memory, way more potential. This is a picture of the latest iPhone 7, and constantly these technology developers are adding more functionality. The newest iPhone, big thing that they're advertising is that it's waterproof. You can take it in and check your Facebook in the shower, I suppose, in the morning. So improved hardware, faster, more memory. Along with the hardware improving, we also have improved software and problem-solving abilities. We have trained the technology, the computers, to do more. This is a picture of Watson, the computer that about 6 years ago went on Jeopardy and beat two of the best human champions at that game show. Watson had a tremendous ability to be able to answer questions and had this almost infinite ability to remember and pick up even kind of minuscule details in answering questions. Interestingly, Watson nowadays is being used as a clinical decision support tool, and programmers are teaching it the field of oncology. So there's Watson Oncology, and this computer is being used to select treatments in the field of cancer. However, it's not just game shows that computers are getting good at. At my own institution here, the University of Alberta, there's a group of machine learning scientists, and they have taught a computer to play poker. And in fact, it's won the World Series of Poker, and there was a paper published last year, 2015, that was called "This Heads Up Limit Hold'em Poker is Solved." So these researchers have basically solved poker. So computers rapidly developing better and better problem solving. The interesting thing about poker is the human element. There's so many there's such a human aspect to this game as people fake and bluff and so on. It took them many, many years to beat poker, and it took a lot of programming power. One good thing about these advances and the smarter and smarter computers, a study recently has told us that robots are not going to try to kill us. Stanford had a 100-year study of artificial intelligence and had this promising information that they're probably not going to turn on us and try to kill us. However, what do we do with this? What does this do for the healthcare professions, and how can we use this within our own work with injured workers? So here I'll come back to the Susskind's, this fantastic book, The Future of the Professions. They are kind of visionaries, and they thought about technology. They thought about the rapid advance of both the hardware as well as the software, and they outlined two potential futures for all of us. Number one is just a more efficient and faster version of what we do today. So our regular tasks with the help of computers are streamlined and optimized. Number two, this is a very different vision. They talk about a potential transformation of how we work, think, and make decisions. And I don't know which one I fully believe right now, but I would say that a lot of the research that's going on in terms of machine learning and the development of clinical decision support tools is aiming at number two, a complete transformation of how we work, how we make decisions, and how we diagnose and treat patients and individuals with health conditions that are leading them to be off work. So when it comes to healthcare, one of the most important things that we as healthcare professionals or people working with people with health conditions do is make decisions. We make very important, critically important decisions in their life. And every day we have the ability to make mistakes that can have profound implications on the individuals that we make decisions for. So the question that I've been struggling with, and many people are struggling with, is how can we make the best decisions? How do we avoid error? How do we make the most accurate and best decisions for the people that we work with? clinical decision-making is very complicated. It's not just looking at the signs and symptoms anymore. The doctor and therapist of today takes into consideration many, many more things. The context of the patient, their work site, what are the job demands, what do they have to do at work, what's their social setting, their social context, not only their family but also their work setting. Where are we working? So up here is a picture of Millard Health, that rehabilitation center where I worked, and because it was owned and operated by the Workers' Compensation Board of Alberta, I know that many of the decisions that I made were influenced by that, and who my employer was and who was paying me. More importantly, lately there is more and more information available online and within the media, and just about every patient or worker that I saw in the last few years of my clinical practice came with opinions, and these opinions were often formed by the things that they were learning in newspapers or on television or on the internet. Here's a picture of Dr. Oz, very famous online celebrity, with a lot of advice that patients listen to and pick up and often come into the clinic asking about. So all of these factors influence our decision making, and for good or bad, we still have the ability to make errors, and our clinical decisions are influenced by the knowledge, all these sources of knowledge and information that we have, but also how we put this knowledge together. So our reasoning process or the logic that we use. Now there can be problems. Our knowledge may be inadequate, inappropriate, or irrelevant. We may just have bad information. Or secondly, we may be putting this information together poorly. So we may have faulty or biased logic, or our reasoning process might be wrong. Both of these things can lead to less than optimal decisions. This is where the help of technology or tools, specifically clinical decision support tools, might come into play and might help us minimize the number of human errors that come into play. So what is a CDS tool? Finally getting to the point here. A CDS tool is any resource designed to aid directly in making therapeutic choices for patients, for those workers with health conditions who are struggling to fulfill their work duties and who may be off work. So a CDS tool is a resource, piece of technology, or a computer program that can help us make choices related to treating these people. Often the tools use patient characteristics to generate specific recommendations. So they're taking the details, the clinical signs and symptoms and those other contextual factors that I mentioned, those patient characteristics, and putting all these things together to generate specific recommendations, specific diagnoses or treatment recommendations for the patients. And like I said, these may incorporate, they may not, but many times they do incorporate technology and the use of computers. Some of the desirable characteristics of CDS tools are that they be easy to use. So these are the things that we want or look for in a tool. Number one, right off the bat, we want these to be easy to use and interpret. Secondly, we want some scientific evidence. We want these tools to be valid and reliable and make accurate decisions. Ideally, they would be inexpensive, pretty cheap, not cost a lot. Lastly, we want them to be meaningful to users. Although one very, very critical characteristics that we want for any tool that we use are that these CDS tools lead to better clinical outcomes. Specifically, we want, when we use them, to improve the functionality and the workability of the individuals that we work with. There are three main types of CDS tool. I'll go through each of these. The first is just called the knowledge base. These can range from something simple as a textbook, which you don't think about it much nowadays, but it is a tool, and it's a very valuable tool that we have access to. There's also clinical journals, scientific papers, and things that are published that we can gain information from and knowledge from. Lastly, there's more and more computer databases that are acting as repositories of information and true knowledge bases. One example of a tool that I turn to almost every day in my work, both as a researcher but also back in my clinical practice, is PubMed. This was the U.S. government created repository of all medical and healthcare related article. So it's an attempt to summarize all of the research literature related to healthcare information in a website, and you can go on there and you can enter keywords up in the search strategy, and it will pop up the most recent research that's been done or articles that have been published related to that. It's an example of a knowledge base. Leaving those, a little bit more complicated CDS tools are things called expert systems. So in these types of systems, the knowledge that were available in number one are extracted, and many times experts themselves, or might be a surgeon, might be an orthopedic surgeon, might be some other healthcare expert who's worked in a field for a long time. Their knowledge and wisdom is extracted, is pulled out, and is codified into algorithms. So these are codified rules developed by peer-acknowledged experts, an attempt to draw upon the expert's knowledge and then program it into a computer. This is an example of one that was published in 2006, a decision support system for lower back pain diagnosis. In this study, a group of orthopedic surgeons were questioned about how they go about making diagnoses for patients with back pain. How do you decide that they have something that might need operated on, or how do you decide that it's non-specific and doesn't need to be operated on? And the research, after this was programmed and tested on a group of patients, they found that this tool was capable of diagnosing or performing at a level comparable to domain experts, so the surgeons themselves. The tool was just as accurate at diagnosing a disc lesion as the orthopedic surgeons themselves. Another tool that I found really interesting, I looked at this a few years ago, was FreeMD. And this was very, very popular before Obamacare in the U.S. It's kind of not as popular as it once was. But this is a free website that you can go on and enter your systems. Again, it's an example of codified rules from healthcare professionals built into a computer algorithm. And after the symptoms are entered, the website itself will sort of spit out the most likely diagnoses. So that's another example of an expert system. The third type of CDS tool is the predictive or classification algorithms. These are data-informed tools that incorporate statistical models and are often run on computers to make it easier, although not always. This is an example of one of these algorithms. It's published in a physical therapy journal, 2011. This is a treatment-based classification algorithm for treatment of low back pain. Now you might not even be able to read these. These boxes are small and the font is very small. I just put it up here so that you can see what they look like. It's a typical algorithm with boxes and arrows, if, then, that. It's complicated, and I don't know of any therapist or healthcare professional that really thinks like this. I definitely didn't when I was practicing, but this is an example of an algorithm that we could work our way through, looking at the specific characteristics of a patient, and then this would help us guide a treatment for that patient. Now this, sometimes you see these up in the clinic, but this was taken and it was programmed into an app called Clinical Prediction Rules, a physical therapy reference. It's available in the iTunes store for about $40 Canadian. Although I wouldn't recommend downloading it. This is a few years old and there have been some better ones that have been released. This one was a little bit too clunky for my liking. But looking at these and the different types of tools that were out there, that led us to think that maybe we should try to inventory or come up with a list of all of the tools that are available for handling workers with musculoskeletal disorders. So we proposed a scoping review to the Workers' Compensation Board of Manitoba, who funded this. Our purpose was to comprehensively search the scientific and the gray literature for information on CDS tools for selecting interventions for MSK disorders. And as I said, our one main goal was to inventory existing tools and come up with a list of the tools that are available. This paper has been published. It was published earlier this year in the Journal of Occupational Rehabilitation. It's open access, so anybody can download it. And if you send me an email, I'm happy to send you a copy of it. Our methods, as I said at the very beginning, we searched healthcare but we also tried to take a broad approach. We looked in computing science literature, and we looked at some of the business and management literature, specifically trying to find tools that might be incorporated at a workplace. Our goal was to identify an inventory of available tools and then comment on the status of the research. Our results. So overall, we found 116 articles. Unfortunately, all of these were in the healthcare. Well, fortunately or unfortunately. There were none that we found specifically published in computer or business literature. Now, I think and I believe that there are some workplaces that are using tools, custom-made tools or whatever, and it may be that they're just not willing to share these or write these up in a journal format to get these published. Maybe it's giving them a competitive advantage, whatever, but we found 116 articles. All of these, the discipline of the lead authors, were from a healthcare perspective. Different types of tools. There's the classification or algorithms, as I talked about. So the bulk of these were clinical prediction rules, classification systems, or treatment algorithms. Most of those from a physical therapy perspective. There were 11 papers written about questionnaires, and I'll talk about some of these in more detail. 6 of the papers presented theoretical or empirical models, and only 5 that we were able to locate, actually wrote about a computer-based tool for selecting treatments for injured workers. Most common condition was low back pain, followed by neck, shoulder, arm pain, and lastly, 10% of the articles dealt with general musculoskeletal disorders. We identified 8 specific tools. 3 of these were kind of low-tech questionnaires or surveys, the Kiel Startback screening tool, the Arebro Musculoskeletal Pain Questionnaire, and the PRICE, the Pain Recovery Inventory of Concerns and Expectations. I'm going to go into more detail on the Startback because it's a great example and probably the most researched and developed tool. You can also see here the computerized tools, the WAT, the Work Assessment Triage tool. That's a tool that I developed along with my research team here at the University of Alberta. There's another called the Decision Support Software, Repetitive Strain Injury Quick Scan. Interestingly, these 2 were designed for use at the workplace, but they were developed by ergonomists, and they still have a kind of a healthcare spin or perspective on them. There's a tool used at the Workers' Compensation Board of Alberta, called the Soft Tissue Continuum of Care, which I'll talk about a little bit, and lastly, a Pain Management Advisor. So like I said, I'm going to talk in detail about the Startback tool. This is a classification tool for low back pain, and it is perhaps the most developed and validated tool. I'm going to use it as an example. I do think that it's a great example of how to go about developing these tools and then implementing them. The Startback researchers, they're from Kiel University. They started probably a decade ago thinking about a stratified approach to management and care of individuals with back pain, and they came up with a theoretical background. They developed this concept of subgrouping and targeting care for primary care low back pain. Their main principle was that patients are not all the same. Every individual, every worker with back pain is not the same as every other individual with back pain, and we therefore should be able to target different treatments to the individual characteristics the patient has when they come into the clinic. The vast majority of patients with low back pain will, they thought, fall into a low-risk group, low risk of chronicity. And that because they are low risk, these people probably will get better regardless of what we do as healthcare providers. What they need if they do show up in the clinic is advice to stay active, reassurance that it is very likely that they will get better, and possibly some medication or other means of helping them cope with the pain. There's another group that faces a medium risk of chronicity. These individuals, they thought, these researchers at Kiel thought, faced physical obstacles to recovery. They might have physical demands at work that are too great, or their functional ability to perform those physical demands might be diminished because of their pain. These individuals, they thought, needed face-to-face, in a clinic, conservative treatment, typically from a PT, kind of traditional physical therapy. The very top of this pyramid is probably the most interesting group. This is the high-risk group. This is the 20% that end up representing what 80% of the burden. These are individuals that often have multiple barriers to recovery and many prognostic factors that might be within the type of back pain that they have, or it might be in their context. So according to this Keel group, quite often these are psychological obstacles to recovery. I kind of believe that there's probably a lot of social obstacles to recovery as well, related to the workplace. However, they kind of stopped at the psychological obstacles to recovery because that's what they could best treat by offering an enhanced package of care, a complex, psychologically informed package of care that was offered by a physical therapist that had been trained by a psychologist. So that was their theoretical background. They then started developing items that could be used in a questionnaire. They narrowed that down to these 9, which forms the Start Back questionnaire. For these questions, the patients are asked to think about their back pain over the last few days. How bothersome is the pain? How bothersome is the pain in the shoulder and neck? If it is spreading up to the top part of their body. And then some other questions: dressed more slowly, walked short distances only because of back pain. It's not safe for a person with back pain to be physically active, worrying thoughts. So this is where the psychological barriers that they talk about here, the psychological obstacles, come into play. These questions are related to anxiety, kinesiophobia, poor recovery expectations, and mood or depression. So it's a simple 9-item questionnaire. The patients fill it out. It's then scored, and the Start Back screening tool produces 2 overall scores. There's 3 kind of categories that correspond to the 3 categories of that pyramid. If their total score is 3 or less, these individuals are deemed as low risk, and they should be offered advice or reassurance. If the total score is 4 or more, then there's a psychology score, kind of a sub-score in the questionnaire that is filled out and tallied up. If they score 3 or less on the psych sub-score, they're considered to be at medium risk of chronicity, and they are offered conservative treatment in the form of traditional physical therapy. If that psych score is 4 or more, they're deemed at high risk, and they're offered psychologically informed treatment. This questionnaire was then, after it was developed, it was tested, it was found to predict recovery, but then most importantly, it was tested in a randomized controlled trial. This was published in The Lancet in 2011, comparison of stratified primary care management for low back pain with current best practice, the Start Back, a randomized controlled trial. And through this trial, researchers found that yes, use of the Start Back did lead to a more rapid recovery. This graph here shows the intervention group, which is the red square line, compared to the control group, which is the blue circle line. And the outcome is mean change in Roland Morris disability scores. So there's a gap here that you can see between the intervention group. Intervention was higher, indicating they had a higher change, more reduced disability, compared to the control group. This was everyone, and interestingly, look at the size of that. If you look over here at D are the patients that were put into the high-risk category according to the Start Back. This gap is a lot larger and shows us that the positive outcomes that were gained with this intervention were largely due to improved outcomes within the high-risk group. A little bit within the medium-risk group, but if you look at the low-risk group, use of the Start Back really didn't make much of a difference. This was a non-statistically significant difference. This one with the high-risk group was statistically significant as well as clinically important. So their conclusion was that use of the Start Back did lead to better clinical outcomes. Now, this is only a self-reported disability score. One limitation was that they didn't incorporate any type of return to work outcome measure, and I haven't seen any trials that have been published since this that have looked at return to work. So I can't really say much about that, and I don't know for sure that use will lead to better return to work outcomes, but it does seem that use of a stratified approach to management with targeted treatment does lead to better functional outcomes. After this trial came out, the researchers then took their paper-based questionnaire and worked with some computer programmers to develop a website, a Start Back Screening Tool website. And you can Google this, you can fill this out online, hit the Get Score button at the bottom, and the computer will provide you with the score, will provide you with whatever category you're in, and tell you what treatment you should get for the score that you got from your responses. Another enterprising company down in the US, MSK2 Media, took it one step further. So this one is free. It's available for anyone at the Kiel University website. This one is not for free, but like I said, it's this enterprising American company that developed MSK2 Media. It is available in English and German, but for $2.99 you can download this from iTunes, and basically what this company has done is taken that paper-based questionnaire and programmed it into an app. So you can have it on your smartphone, you can have it on your iPad, you can have it on a tool in your clinic. Patient fills it out. It's quite nice. It's a lot more interesting than filling out a paper and pen questionnaire. You can't see it here, but kind of gives you a sense that the pages scroll up. So there's some graphics, a graphical component to it that makes it more interesting. The questions are the same, and it will give you an outcome, just like that website did. It'll tell you what category you're in and tell you the recommended treatment. So that's the Kiel Start Back Screening Tool, and like I said, I think it's probably the best example of a tool that has been developed all the way from the theoretical thought about a stratified approach through to development of a questionnaire, testing the tool in a randomized trial, and then taking it out and having it put into an actual tool, a computer-based tool that you can use in a clinic. That does all the scoring for you. Two of the other questionnaires that we found when we were inventorying and conducting our study, the Cerebro Musculoskeletal Pain Questionnaire, the OMPQ, as well as the Pain Recovery Inventory of Concerns and Expectations. The Cerebro is probably the second best to the Start Back, and it also is available from this company, so you can get the Start Back. You can also get the Cerebro from MSK2 Media and have it on your smartphone. The price is newer. This is one that's being developed by Bill Shaw, and colleagues at Liberty Mutual in the US. The questionnaire has been developed. It's a little bit longer than the Start Back of the Cerebro. It is, I understand it, is 47 questions. It's a little bit more comprehensive, and it also takes into consideration a lot of the work-related barriers. So those social barriers to recovery, not just the psychological barriers to recovery. And if anybody wants this, I'm happy to share. Bill Shaw has developed a manual, and he's willing to provide this free of charge to anybody that is interested in looking at it further. I want to move now, though, into the computerized tools that we've found. This is what we had hoped to find. I was surprised that there were only 5 developed, or at least 5 that we were able to locate with our literature review, but I'll go into some detail on these. First one is the Work Assessment Triage Tool. This is a tool that we developed using data from the Workers' Compensation Board. It is a web-based tool for selecting rehabilitation programs for injured workers. We started this about 6 years ago. We had access to the WCB Alberta database, and we were able to obtain information on about 14,000 workers. We had detailed information about them, about their diagnosis, about their workplace, about their demographic and personal characteristics. We also knew about their clinical characteristics, the treatments that they received, and the outcome from those treatments that we received. So taking this big database, I partnered with some researchers from a machine learning laboratory here at the University of Alberta, and we developed some algorithms using machine learning techniques. We then took these algorithms and programmed them into a web-based tool. Within our early studies, we tested internal validity, and one of the things that we found, which was great, is within the database, that database of 14,000 claimants, we found that the tool, these algorithms, were able to detect or recommend the treatment that led to a positive return to work outcome with a higher accuracy than the humans that were doing the same thing. We had information about the clinical recommendations that were made by therapists. They were about 85% accurate. Our algorithm went up to about 93% accuracy. Now that's not unexpected when you're testing it and doing an internal validity study. So you do expect that kind of high accuracy within the database that the tool was developed on. We've also done one further external validity study where we looked at another database to see how accurate the tool was compared to humans, and it was not quite as good. We found only moderate agreement compared to humans, but an interesting finding was that our tool, the WAT, was more likely to recommend treatment programs that were evidence-based. One very common one that is supported by a lot of literature are workplace-based interventions, actually going out to the workplace and using a participatory ergonomic approach to either reduce the physical demands or brainstorm how to reintegrate this individual into the workplace. The humans were not as likely to recommend it as was our computer-based program. Now you're able to access this tool on the Ignite Physio site, ignitephysio.ca/WAT. I'll show you a screen capture of it here. Basically, there's 18 characteristics that you would fill out with drop-down menus. Does a worker have a job to go back to? Yes, no. Occupational category, here it's trades, transport, equipment operators. Are they currently working? So after these 18 drop-down menus are filled, you then hit predict. The outcome looks like this. You are provided with a prediction from the positive rules. These are rules that recommend a treatment that you should consider that's likely to lead to a positive return to work. There's also a prediction from negative rules. So these are rules that are likely to lead to a failed return to work. So based on these characteristics entered in the drop-down menus, this worker should not enter a complex chronic pain program. They should, or the therapist or whoever is using this tool, should consider either a hybrid program where there's a functional restoration component combined with an integrated workplace component, or only a workplace-based program, or only a provider clinic-based functional restoration program. The tool will give an estimated number of days, as well as a confidence that the computer is, a level of confidence that this program will lead to a successful return to work. So that is the WAT, and as I said, we've published 3 papers on it. If you want more information, contact me or explore that website. Another one was published in 2005. This is the Decision Support System. This is a spreadsheet-based database to help ergonomists better match workers with the work environment. This is one of those tools that I said was developed by an ergonomist for use at a workplace. It was designed specifically to identify ergonomic risks for individuals at risk of coming down with a work-related upper extremity disorder. It doesn't have a lot of research backing it. We were only able to find one study, and this was a qualitative study looking at perceptions of the users at the workplace. One other limitation of it was that it was specifically developed for only one workplace. So I do worry a little bit about the external validity or the generalizability of using this tool at other workplaces. But it's a nice step forward looking at a tool of matching workers with their work environment and allowing a computer to come in and help you with this kind of a decision. Now the one that has been used in the Netherlands is called the RSI Quick Scan. There's a researcher that did his PhD thesis on this tool. It was developed to evaluate risk of a repetitive strain injury, RSI being a repetitive strain injury, in work or office workplace. It's designed again to help ergonomists to match the employer to the workplace or identify when there is a risk that needs to be acted upon and minimized. There's a few studies, and one was a randomized controlled trial that found that this tool actually was not cost effective. And so that kind of put a damper on marketing and so on. It's still in use by one company, Arbo Uni, but there hasn't been a lot of uptake. Basically, it was just too expensive for the outcomes that were obtained with it. Another one is the WCB Alberta Continuum of Care. Now I link this in with the computer-based tools, although it's not totally a computer-based tool. There's 3 components to it. A continuum of care basically is a staged application of rehab or healthcare services, providing the appropriate care at the appropriate time or the stage of recovery for that worker. I consider this a computer-based tool because there was some programming done to come up with computerized prompts for the case owners, or the claim owners, case managers and adjudicators. So these were protocols that were built into their computer when the case manager or the adjudicator would come in first thing in the day. If one of their workers had hit a point in their recovery where it was time to consider a new treatment, a new assessment, or something else, there would be a window that popped up on that case manager's computer, and they had to interact with that window and close it before they could go on with their other tasks for that day. So there were these computerized prompts. On top of that, there was contracted services with providers, and there was a lot of evaluation and contracts put in place with the healthcare providers to act on these recommendations that were built into the continuum of care, as well as these computerized prompts of the case manager. Impact and effectiveness of this model has been evaluated. We published one study in 2007 on this, and this tool is still clinically used by the Workers' Compensation Board of Alberta system. It's been modified a little bit. The study that we did show that it was cost effective, and basically this is the continuum of care. This is the newest version of it. So like I said, there's a staged approach to care. At the top is this timeline from the date of injury through to 18 weeks post-injury. From the onset throughout, there is case management involvement as well as medical management. And then at different stages of the injury, there's different types of care. Active PT, chiropractic and acute. There's a return to work assessment if the worker has not recovered by 6 to 8 weeks following this acute treatment stage. And then following the return to work assessment, if the worker is still not ready to return to work, there are these different rehabilitation options. This is where we developed that WAT tool to help these clinicians completing these return to work assessments to pick from these different options that are evidence-based and supported. The last tool is called the Pain Management Advisor, PMA. It was designed to enhance management of chronic pain, and it looked at different treatments, opioids, NSAIDs, and so on. And it had computer-based, rule-based algorithms that were derived from expert knowledge of pain specialists. I really wanted to look into this more just because of the real problem that we have nowadays with narcotics and opioids, but there was limited information available. We couldn't contact the corresponding author. The email in the article, the one article that was published, was not responsive, and so I don't have a lot more to say about this. But it would, I think there's a ton of potential for something like this. So that was our inventory. So our study had a few take-home messages. CDS tools are available. There are a few, there's a growing number that are available that may improve patient care as well as return to work outcomes. We can say that computer-based CDS tools are rapidly developing for use in clinical settings. Although right now, I think that they're probably at the stage where it's not quite ready for prime time. I'm a little bit hesitant to recommend widespread use of any of these tools even that start back tool, like I said, has not been tested outside that one RCT. It hasn't been tested in other contexts and settings, and there has been no one that has looked at whether it leads to better return to work outcomes. So we were kind of cautious in this paper. We think that computerized tools may in the future allow therapists and healthcare providers and all of the other frontline professionals working with disabled workers to make data-informed decisions. But there's definitely a lot more research that needs to be done. So just acknowledge our funding source, and then I'm going to open it up. I wanted to keep about 15 minutes for questions at the end if anyone has questions. WCU Manitoba did fund this. You can see our co-investigators here, and then some of the partners. So, Tanya, I don't know how you want to do this, but can we open it up for questions?
Absolutely. So at this time, I don't see any questions that have been typed in, so I would encourage everyone to type in any questions you have for Doug. In the meantime, Doug, if I email you after the event, can you provide me some links to some of these resources, to some of the tools so that I can, and some of the research, just so I can post them for people for easy access?
Sure, yeah, I definitely can.
Okay, that would be great.
I'll send a link to that article as well.
Wonderful. And have you found, so in your work, I mean, you did a lot of comparison and seeing what's out there. Did you, or is work being done on actual research being done about how these are being used in workplaces? Is that?
Well, we looked at that, and I was really hoping to find some information about that, but we didn't find anything.
Okay.
One of the co-investigators here was Kelly Witt-Williams. She has a background, clinical background as a nurse, but also has an MBA, and she specializes in, well, she's kind of in a department of business and management, and we worked with her to search this business and management literature, and we couldn't find even one article. So I don't know if people are just kind of keeping these and trying to maintain their proprietary secret so they don't give other people competitive advantage, but it definitely isn't written up in the literature.
Gotcha. That is really interesting. It would be interesting to know how employers, if employers and how employers are using tools like this. Let's see, we still don't have any questions, so I mean, everyone feel free to type it in.
Maybe I'll give you one more quote. This is a quote I had second thoughts about sharing, but this was from Ken Olsen, 1977. This was the CEO of Digital Corporation. He had this quote, "There's no reason for any individual to have a computer in their home." And you know, he's so incorrect. But I definitely think that there's still a lot of people that have this kind of an attitude, especially when it's a healthcare setting. I mean, I know many therapists and doctors who still kind of have this attitude. There's no reason for any individual to have, any clinician to have a computer in their clinic. But hopefully we're past that and can kind of see the potential of these tools, because I think they're just gonna grow and get better and better.
Yeah. Let's see, we have gotten a couple questions now. So one person asking, why would a generalized tool be of more benefit in clinical decision-making than a health professional's judgment?
That is a good question. A generalized tool, well, I would say that there's different types of tools. So one of the ones that I showed was a generalized tool. When I say generalized tool, I mean it will work for all MSK conditions. When I talk about a specific tool, a specialized tool, that would be related to one specific condition. I think that the potential of these tools, whether they be generalized or specialized, they have the potential to minimize error. When it's a human making decision, we're subject to biases. We definitely make decisions and have the high likelihood of making errors anytime we do that, whereas the use of a computer has potential to get rid of some of these cognitive biases that come into play with the humans.
All right, and let's see. As a clinical counselor, we are not normally part of the process for providing information. How could we become part of this network of supports on the return to work team?
Can you read that again? As a clinical counselor?
Yeah, as a clinical counselor, they're saying they're not normally part of the process for providing information. I think they probably mean providing information, maybe feedback about these tools. But they're asking about how could we become part of, to study groups, they said, providing information to study groups. How could we become part of the network of supports on the return to work team?
Well, that's a good question. I can't say that I know for sure what a clinical counselor does or what setting you currently work in, but I do know that most of these return to work teams are very open, and more they're looking to do outreach and network with people at workplaces and insurance companies and other settings. So I just think in general there's been an openness for healthcare professionals and these return to work teams to move out of their clinic, out of the silo that they have been working with, and partner with all kinds of disciplines and individuals with other expertise. So it sounds like you would bring some information and some really valuable knowledge and wisdom that these return to work teams would probably benefit from. So there's probably lots of people around that could put you in touch with them. If you don't know where to look right now, feel free to email me afterwards. I kind of only know the ones here in Alberta, but there's others across the country.
Very good. Let's see. The same person who that last question was about said they work with clients in rural areas, and so computer connectivity would truly help the client participate as well. And they look forward to having this area grow of research and interaction and using technology this way.
Yeah, thank you. I definitely agree with that.
And then someone asking, do you see non-healthcare professionals trying to use these types of tools to apply expectations of recovery to individuals' cases?
I definitely think so. You know, I think that a lot of these have been developed by and for healthcare professionals, but I don't see a lot of risks of other people using this and informing their day-to-day decisions, especially something like the StartBack tool, even our WAT tool. It's out there. It's available and people can use it. I know that I work closely with the Workers' Compensation Board here, and we have worked with them to implement some questions related to expectations of recovery that are asked by the claim owners or the adjudicators right off the bat within the first 2 weeks of the claim. And we are hoping that this information is useful to the claim owner and that they use this to guide their decisions. This is very general, non-medical kind of information. Does the person think that they're going to recover? I think everybody on the team, everyone that's interacting with the worker should know that. And if there's a barrier, if they don't, then we all need to work together to overcome that. The only risk would be is if there's a tool that's recommending one specific type of treatment and then trying to implement that, you might have to refer on to the appropriate professional that can do it.
So that actually, some of your answer leads to a question that I have. How are you doing more circulation of that? Like, essentially, how are you getting the word out about the tools, especially the ones that you've developed, since you may not be able to speak to other people's tools, but like in regards to marketing or like how you're encouraging workplaces for uptake?
Yeah, we are, well, I'm talking to everybody I can, doing this webinar. This is one way to do it. So this is, getting back to the screen here, this is our WAT tool. And this was not the original version of it. The tool that I created with a grad student was very, very ugly. It was much more gray and not as user-friendly. So I did work with the owner of Ignite Physio, which is kind of like a Facebook for therapists. for physiotherapists, and he worked to kind of program it into this much nicer looking interface, and what we are doing is making this available free of charge. So it's out there. There's some videos that he and I created that are instructional videos that will teach people how to use it. So we're trying to get the word out online and share it with as many people as we can.
Great. Well, I will definitely be sharing it through to our social media followers and other things, because I think it's a really great tool that can be used, and it's good to spread good tools.
I agree.
Okay, I think we don't have any other questions, so I'm going to go ahead and close down. Thank you very much, Doug, for the presentation and for all of the great resources. I'm looking forward to being able to provide some of these links for people to access nice and easily and in one spot, so that's really great.
Well, thank you for the opportunity.